Let's review the use of botulinum toxin injections for oromandibular dystonia. I would like to start by thanking my wonderful family in University of Nebraska Medical Center who helped me train, educate, and become skilled and expert on use of botulinum toxin and movement disorders. And I would like to dedicate the talk to the memory of my father who wanted me to be an educator. In this presentation, we will be reviewing the essential features of different subtypes of oromandibular dystonia and the common muscles that are involved. We will discuss some basic injection planning for these different subtypes of oromandibular dystonia, and we will understand and discuss common techniques of injections for different subtypes. So let's give a clinical context. Let's say you are having a 32-year-old female presenting with pulling and tightness in the jaw. She had it for more than 5 years, but recently it's gotten worse. She reports difficulty chewing and having pain in front of her teeth for years. She had multiple dental procedures done for her teeth, misalignment without sustained benefit. She has tried and failed pain medication and muscle relaxants. So in this situation, does she have oromandibular dystonia? What is the likelihood of benefit from botulinum toxin injections? And how would you plan for injections on this patient? Oromandibular dystonia is dystonic contractions of the masticatory muscles, facial muscles, pharyngeal, tongue, and lip muscles in various combination. That also divides it into various subtypes. The dystonia or dystonic contractions are intermittent, paroxysmal, and they're sustained briefly. They can vex and wane. They're almost always bilateral, but they could be asymmetry of involvement. And about half of the patients will exhibit isolated cranial involvement. But oromandibular dystonia can be part of a generalized dystonia or a craniocervical or segmental dystonia. Botulinum toxin treatment improves quality of life in patients with oromandibular dystonia as measured by Glasgow Benefit Inventory and Dystonia Questionnaire. So for sure is useful for treatment of oromandibular dystonia. Clinical benefits are sustained over time, and these are the references that you can review for support of this therapy. Some of the common types or subtypes of oromandibular dystonia will be jaw closing dystonia, clenching of the teeth. A similar related condition is bruxism. Most people consider bruxism as nighttime clenching of the teeth and not during the day, while a jaw closing dystonia is clenching of the teeth during the day or while someone is speaking. Jaw opening dystonia when they have trouble closing their mouth. Lingual dystonia when the tongue wants to come out. Perioral dystonia when the lips want to purse or pucker in different forms. Mixed dystonia, we may have combination of the above, and segmental dystonia, where dystonia is not just in the oromandibular area, but also face or neck area. There have been 9 studies of type A botulinum toxins, totaling 387 patients with isolated focal oromandibular dystonia, showing an average reduction of 39% or 40% compared to control. But there is heterogeneity, variation between studies because of design, patient population, and so on and so forth. Complication rate has been common or high in these trials, 27%. In the clinical trial, we usually use high doses to show benefit, and that way we often overshoot, and we usually don't customize for individual patient. Most common side effects that were reported in these studies were dysphagia, jaw weakness, weak smile, dryness of mouth, dysarthria, and injection site pain. So these are the trials. On this graph, you can see that overall pooled analysis clearly favors botulinum toxin injection. Some of the individual studies also favor, but not all of them. And there is variation in terms of benefit reported by these different studies. These are the studies. The diagnosis involved the muscles injected and % favorable response. If you look at the N, the largest study is from Tan and Jankovic, 162 patients, but many other studies are respectable. Sankla was 48 patients, Rosales was 50 patients, Sinclair was 49 patients, Charnuka was 42 patients. Person with favorable response has been high. The lowest response I see is 40%, and many showing response rates of 100%, everybody having some benefits, especially in the smaller studies. Muscles injected, of course, varies based on the type of dystonia, but involve all these common muscles that we will be looking at later on, and all of them involved a type A toxin is various dose ranges. So there is AAN class 2 evidence as summarized by the Lee et al. Study in 2010 and the earlier study of Jankovic in 87, and showing clear benefit in a properly designed study. There are 6 steps to success in any botulinum toxin clinic, and that is true for cervical dystonia, that is true for blepharospasm, but is also true for oromandibular dystonia. You need to make the right diagnosis. The type of muscles involved, the type of movement, dystonic movement sometimes can be confusing. You need to do the analysis of abnormal movements to figure out which muscles are involved. You need to do analysis of muscle involvement in terms of more or less involvement, asymmetric involvement. You need to then plan for correct dosing in the right muscles, higher and lower in some muscles. And then you have to do those correct injections in the proper injection techniques. And finally, based on the patient's response, you adapt to the therapy. I will go through these 6 steps as in regards to the oromandibular dystonia, starting with number 1, right diagnosis. Here is a patient with oromandibular dystonia providing you her extensive history of how hard it has been for her to get the right diagnosis for her dystonia.
My ear was starting to hurt. So I went in and she said, no, my ears were fine, but she thought I was getting sinus infection, so she put me on amoxicillin or Augmentin.
Mm-hmm.
She said after 5 days, call me if it didn't get any better.
You can see the jaw movement she was having, and to a point where she had to hold the chin with her jaw. The early kind of a stuttering kind of a jaw movement you saw, you may have thought there was just nervousness or anxiousness, but later on, now she's holding her jaw to try to support it. She's telling her how she's going from physician to physicians with different trials of medication without ever getting a proper diagnosis.
And so I called her, she gave me another round of it. Went back in and she goes, I think you have something's wrong with your teeth. And I knew better, but I went, okay. So I went to my dentist.
Mm-hmm.
My dentist thought I had a stone in my parotid gland.
Mm.
He said, you need to get that checked immediately. Went to my ENT. He sent me to get an MRI done. The MRI showed there was nothing in my parotid gland. He told me he thought I had a severe case of TMJ.
TMJ is temporomandibular joint problem. I paused it to show you that sometimes she's just barely touching her jaw. It isn't that she has to hold her jaw strongly all the time. And sometimes just touching her jaw seems to calm her jaw movement down. And that seems to impair with her ability to speak. There's also some creases on her lips, both upper and lower. There's increased mentalis fold. There is increased creasing on the lips as she's speaking.
Went to a TMJ specialist. Walked out of there, shook in my head, thinking, no. So then I went to my chiropractor, and he did 3 rounds of 10s on me. And he said, Wendy, I'm not doing you any good. He goes, you need to go see an orofacial doctor. So that's when I went to see Dr. Reek. He's a Nebraska orofacial doctor. And he gave me some anti-inflammatory medicine, and that helped a little bit. In the meantime, my daughter works at Bryan Hospital. Found out there was a thing called sphenocath.
Mm-hmm.
So I went to see Dr. Pfeiffer from Advanced Radiology, and he did 3 sphenocaths on me. My last one was in November of 2018. My first sphenocath, I think it helped a little bit, but my second and my third one, I didn't see any improvement. So I got myself through the holidays this year, and my daughter says, you're going to go see a neurosurgeon. So I went, the beginning of this year,
So you can see that the patients are often misdiagnosed and they are treated for various different diagnoses before finally getting to the right physician or neurologist. And this is very common for many movement disorders, but especially oromandibular dystonia. Let's look at her examination now.
Was my ear was starting to hurt.
Uh-huh.
So I went in and she said, no, my ears were fine.
You check a few things on you.
Okay.
Relax your hands on your knees and sit up straight and close your eyes and just relax. Let your jaw do what it wants to do. Don't try to fight it and let it happen. And don't resist and just relax. So already you can see some problem in terms of diagnosis. Sometimes she's chattering her teeth and she's clenching her teeth and is chattering. And then now she's opening her teeth when I told her just relax and let it do what it wants to do. Now the question is that is it a jaw closing dystonia or is it jaw opening dystonia? And which one is compensatory? Because if you have a jaw opening dystonia, you will compensate by trying to push your jaw in and trying to clench your jaw teeth to try to speak, so don't let it open, because if it open a little bit, it will just go all the way. Or if you have a jaw closing dystonia, you may compensate by trying to keep your jaw open so it doesn't clench on you all the time or bite your tongue, so you will speak with mouth open a little bit. So that's a problem, that we have primary dystonic movements and compensatory movements all the time in someone with dystonia, and trying to separate them out could be a little challenging. Very good. Open your eyes. Can you try to close your jaw? Okay. Do you have a trick to help you close it?
I can help me,
By touching your jaw?
by touching
Do you have to push on your jaw or just touching is enough?
kind of, if it's really bad, I got kind of a nudge, but just kind of holding it really,
Lightly is enough?
yes.
Okay, all right. So that's typical for gest antagonist. Gest antagonist is a sensory trick which helps overcome a dystonic, a powerful, forceful dystonic movement. So often touching or rubbing or slightly, caressing is enough to get rid of the dystonic movement. for just antagonese. And you can see that when her jaw is closed, she just try to keep it closed and speak as if she has a jaw closing dystonia. But her primary problem seems to be that the jaw wants to open, and then she has trouble closing it once it opens up. Just relax, and you check a few things on you.
Okay.
Out your tongue. Relax. So right here, I was trying to pause, and sorry, I went back. But what I was trying to show you was the perioral involvement. We previously noted some creases on her lips, and now look at her lip on how the lips are being turned in. So it's not just jaw opening, but also a pulling of the lips in addition to it. And so pay attention to that as I play the video, that part again.
Yes.
Okay, all right, just relax. Look at the lips. And then you try to stick out your tongue and move it side to side. Very good. And just relax. Very good. Close your eyes tight. Really hard. Hard, hard, hard. Now open. When you ask them to do other movements such as closing your eyes tight and hard, a lot of time what we're trying to do is to cause an overflow or bringing out of the movements, dystonic movements, because of doing movement somewhere else. And there is an overflow of the normal motor plan into this dystonic motor plan. And you can now see the opening of the jaw and the pulling of the upper lip and maybe even lower lip when she's trying with from her dystonia. Okay. Very good. And can you say pa 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 pa?
Hum. Pa, 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 pa.
La 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 la.
La, 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 la.
Ga 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 ga.
Ga, 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 ga.
Ka 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 ka.
Ka, 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 ka.
Very good. Can you hold a few sounds for me? So, like I'm doing. So take a deep breath.
No, I struggle with that because singing in church,
All right. I think we got most of our features, so let's move on. So, analysis of movement is important. You can have a jaw closing dystonia, you can have a jaw opening dystonia, you can have a jaw deviation from side to side, you can have a tongue dystonia, you can have perioral dystonia, or a combination of these. So, let's look at some classic example of these different forms of dystonias. Here is a patient with jaw opening dystonia. Patient has his mouth open. The camera is maybe a little too close, but the point is to show how aggressively the jaw is open, and patient is hurting because of the muscles are really pulling his jaw out, and he's having trouble closing his jaw, keeping his jaw closed. Now here's a patient with jaw closing dystonia, and you can see that the clenching of the teeth often destroys the teeth. She has, probably loss of complete upper dentures and damaged lower dentures, and that is likely because of the excessive biting and clenching of the teeth patient is doing. Usually, jaw closing dystonia, masseter is the strongest muscle of the body per inch basis, and is powerful enough to destroy or damage your teeth because of aggressive dystonic contractions. This is a jaw deviation. You can see that there's misalignment. The lower midline of the jaw of the lower jaw is on the right of the patient as compared to the midline of the upper lip or upper jaw. And then here's a tongue dystonia with some tongue twisting involved, causing a lingual dystonia. And there can be combination of the above. Muscles involved. So once you have figured out what abnormal movements there are, you have to figure out which muscles are involved. So possible muscles that can be involved: jaw clenching will be masseter and temporalis. The perioral will be orbicularis oris. The jaw opening and side to side movement will be medial pterygoid and lateral pterygoid and digastric. And the tongue involvement will be geniohyoid mostly, or sometimes mylohyoid. So let's look at some of these muscles anatomy in more detail. So jaw closing dystonia, the two muscles that you're primarily targeting will be the temporalis and masseter. Probably the most common form of jaw dystonia is the jaw closing dystonia. Another variation is bruxism, I mentioned earlier. Very easy injections to do. These are the subcutaneous muscles just below the skin, and very easy to identify and inject them in temporalis and masseter, and dosing is relatively easy. Masseter injections, these are the common sites. One easy way is for you to try to feel the interior edge of the masseter muscle and ask the patient to clench their teeth and relax, and clench again and relax, and you can feel the interior edge of the muscle moving. Once you have figured that out, you go about a finger breadth behind that interior edge to give your first shot, and then you go about a finger's breadth above the edge of the jawbone. So you are still close to teeth and you are a finger breadth behind, and you want to go below the skin. If you're not far enough behind, there may still be some parotid gland. So you want to go through that subcutaneous fat into the muscle. EMG is ideal, so you can feel when the needle enters the muscle. Because of the EMG, either from the dystonia or the clenching of the teeth, you ask the patient to do, and then you can inject there. And usually you can give one shot if you're giving 15 to 20 units, or 0.1 to 2 ml. If you're giving more, then it's probably better to give two separate one, because it's a thin muscle and the drug can just exude out. Temporalis muscle. Temporalis is very easy to identify. I have talked about these are the same markers we have used for the Botox injections. You can use the same markers also for temporalis injections for the dystonia. The dose would likely be higher. Typically starting doses anywhere from 10 to 40 units, depending on how much dystonia there is. You can even see hypertrophy of this muscle if there is a true dystonic involvement. All right, jaw opening dystonia opening of the jaw, the most powerful force for opening the jaw is gravity. However, there are two muscles that do play a role in opening of the jaw. The weaker role is from digastric muscle. It's a ideally situated muscle, but it's a very thin muscle. So it runs under the chin, just parallel to the midline, and then goes back to the hyoid bone. There is a posterior belly. We typically don't inject it. We inject the anterior belly of digastric, which is usually the thicker one. And the injection is about a finger breadth behind the edge of the jaw and a finger breadth or half a finger breadth lateral to the midline and just under the skin. Sometimes, especially if it's involved or hypertrophic, you can even feel it. The other muscle that helps open the jaw is activation of lateral pterygoid muscle. It's a weak opening of the jaw muscle. Its more job is side-to-side movement, but when bilateral pterygoid is involved, then there is no side-to-side movement as much as opening of the jaw. When they both contract strongly, they do open the jaw because they cancel each other out side-to-side movement. Then they become mostly a jaw opening muscle. The pterygoid muscle is behind the jawbone, this ramus of the jawbone. So there is various ways to get to it, and we will review it in later slides. This is anterior belly of the digastric, an inch behind the edge of the chin, and a finger breadth behind the interior edge of the jaw, and a finger breadth lateral to the midline or half a finger breadth. Lateral pterygoid. So lateral pterygoid muscle, one way to get to it, which is my favorite muscle, way is to find that U on the upper edge of the ramus of the mandible and then open it up by opening the mouth partially. And then there is a dip that happens there because of the loss of overlap of the bones, and there's a window that opens up above that jawbone through which you can go deep. So you go anteriorly 45 degrees and slightly superiorly through that window, and then you get to that pterygoid muscle. There is an internal, an intraoral way too that I will show later. So the intraoral way is to find a pterygoid muscle, which is the innermost muscle on the edge of the jaw behind the ramus. You can actually feel it in yourself and in patients. You identify it and you can inject it with the needle. It's a very, very strong muscle. I can almost see the needle being slightly bent, or maybe was intentionally bent to go around the braces to get to that jaw. This may be for a block for the nerve, but you can also get to the muscle the same way. Lingual dystonia, tongue is just single muscle. This genioglossus muscle is basically the whole tongue. It has a base and then it comes out as a tongue. We don't inject the upper tongue part. We inject the base part. You can approach the base both ways. You can approach it from below here, straight into the jaw if you go in deeper to the digastric or even sides at the side of the digastric. Or you can even approach it from inside. If you open your mouth and lift your tongue up, the muscle at the base below the tongue that you see is also genioglossus muscle. There's only one muscle that is forming the floor, the roof, the floor of the mouth and the tongue. All right, so these are the recommended starting doses. 20 to 40 units per side on masseter, 20 to 40 units per side on temporalis are reasonable starting dose for type A, Botox, and Xeomin. And then for pterygoids, 50 to 30 units, probably 15 to 30 for lateral or medial pterygoid is reasonable. For tongue, much lower dose, 5 to 10 units. With the tongue, you don't want to cause too much weakness of the tongue. When the tongue becomes weak, it falls back and then can cause trouble swallowing and can cause worsening of the sleep apnea and problems like that. So you don't want the tongue floor to be too weak. So just a little bit. Although it's a big muscle, but the doses are very cautious and conservative. I would probably start with 5 units and 10 if there is clear hypertrophy or severe involvement. And these are the tongue injections I was mentioning before. Genioglossus, it's listed as 10 to 30. I think they'll be too aggressive of a dose. I have given 20 to 30 units, all the way up to 40 units in one of the tongue, but I will escalate to it because you don't want to overshoot. You don't want to cause trouble swallowing. You will scare the patient away. All right,
very good.
Let's look at some injection techniques. So this is
and
injection
relax.
for the masseter muscle.
Relax.
I am trying to feel
Good.
the interior edge of the muscle.
And clench your teeth again. Very good.
Right, so I am
clench.
feeling the muscle, feeling the interior edge. Now I'm going to go a finger breadth behind the interior edge and then a finger breadth above the edge of the jawbone to get into the muscle, and I'm trying to listen for EMG. This patient has a deep brain stimulator implanted, so that's why she's having a lot of static noise rather than a true EMG signal.
Alright. And clench your teeth again.
All right. I think there was also temporalis in that patient, but it was probably very easy, so I may have skipped it. But adverse effects are not very common if you select the muscles right, if you make the right diagnosis, but up to 10 to 20% of patients, and in the review, there was up to 27% with the side effects reported. The main side effect to watch will be dysphagia. It's less common with the jaw injection in terms of the masseter temporalis, probably more common with the throat or tongue injections or deeper pterygoid injections. Dysarthria can happen, drooling can happen, dysphonia can happen. Tongue injection can cause dysphagia much more severely, and acute pain can sometimes happen with lateral pterygoid if you don't inject it right. Hematoma, especially, will be very painful. Here are some tips for the injections. Masseter, avoid the parotid by targeting the interior part of the muscle. So you feel the interior edge and just a finger breadth behind. You don't want to go the masseter behind. There is masseter there all the way back, but then there's parotid gland for quite thick over it, and you don't want to give it just above into parotid. That will cause significant dry mouth. Lateral pterygoid, and when you put the needle in to inject with the mouth partially open from outside, ask the patient to keep the mouth open and don't close their in. If they close the jaw in, the window closes and that will severely bend the needle and you will not be able to pull it out without patient opening the mouth, and it will become more painful. Digastric, when you're doing it from down here, don't make it deep because digastric is a very thin muscle, and just below digastric is the genioglossus or the tongue muscle, and you will cause tongue paralysis or weakness and high risk of dysphagia. Very good. If so, now the last step, you did everything right, you did the injection technique, the diagnosis is right, and the patient does not respond and is here for a follow up. A poor response, you want to make sure your diagnosis was right. It was not a jaw closing or a jaw opening dystonia, and you diagnosed it opposite. You want to make sure your muscle selection was right. You want to start increasing the dose. If the patient had no side effects and had no benefit, then that means the dose was just too low, and you increase the dose and look for benefit at a higher dose. And you quantify response with some objective measurement. Sometimes patient is not 100% reliable, and you want to watch for those primary non-responders and who just never respond to the toxin, which is rare. All right, for oromandibular dystonia, here's the bottom line take-home messages. Botulinum toxin is clinically helpful in patients with oromandibular dystonia. Possibly less benefit in patients with jaw opening dystonia compared to jaw closing dystonia, and the most riskier for the tongue dystonia. And perioral dystonias I did not touch on. That is also hard to do. If a successful regimen is found, benefit is likely to happen all for forever. So you can keep doing it every 3 months. Same thing, and you keep on getting benefit. A dental prosthodontic evaluation might be helpful, especially for jaw closing dystonia, because they have significant teeth damage and you will need support for them. But it will not work unless you also do injections at the same time to try to calm down the muscles. That's all I had. Thank you so much for your attention. I will look forward to discussing this more in the workshop.